Luca, another biker. Let's see the case. Is it an AVM case or? Okay.
No, I don't think. So hello, thank you. It's a not really dramatic case, but it raised a lot of questions, and we still do not have the answers for that. So good to have the possibility to share our doubts. 65 years old female. She's in another hospital, aphasic from the day before, no other deficit, high blood pressure. They perform CT and CTA. This is the CT. There are some spots here and here. And at the CTA, which is performed elsewhere, there's an occluded left common carotid. You can see here this naughty aspect and no carotid. So obviously this is a small hospital. They ask us what should be done. And for some reason, we think it's not really an emergency case. Oh, sorry, it's not finished. The common carotid is not there. And then there's probably a kind of occlusion or near occlusion of the MCA, of the left MCA, which is consistent with the symptoms. So the patient is transferred to us, but we just keep the patient in the ward overnight, and it comes. No, sorry, he stays in the spoke overnight. Then it's sent in the morning, and she arrives by midday, stable, no new symptoms. So we do the angio. This is the right carotid. And this is, as expected, the occlusion of the left common carotid. Some collaterals. This is the cervical that goes backward through the ECA, through the occipital to the external, which gives some revascularization of the siphon, meaning that probably there's some need for additional blood coming even from a very long collateral. So it means something to us, right or wrong, I don't know. This is the vert with very good collaterals in the leptomeningeal hemispheric, and this is the collaterals from the PCOM and the occlusion of the MCA as we saw it on the CTA. So we decide to go for a possible revascularization. I know it's arguable, but we felt that that do something was needed. So we go through the occlusion here with a microcatheter and micro guide wire. We try to go further up with a aspiration catheter. This is the guiding. So we go up with the guiding catheter. Then we push the aspiration catheter, but it doesn't go up. So it felt like a very tight stenosis or tight plaque or whatever. We couldn't see anything. Obviously, it was a blind catheterization.
It was a 6 French or?
It's a
aspiration.
I guess a Sophia 5 on inside a Neuron Max. That's likely. So nothing to do. So we go up with a balloon, do a predilation, and then not much of a good result. It stays pretty occluded. So we decided to go up with a stent, and we stented it, which is always a tough decision, because you know that you will have to start with all the anti-aggregation protocol, and it might bring some complication, further complication in the following days. But anyway, that was felt like needed. So we went for that. No result at all. So the stent is there and there's no flow. So further dilatation with the balloon. A little bit better. We confirm the MCA occlusion, which is seen better now. This segment is bad looking. So we go for dilatation of this segment. So everything is better than before. So eventually we can go for the thrombectomy of the MCA, which was the main target of this procedure. Here it is. We go with the same aspiration catheters, which is quite easy and quite quick. So it's okay. Everything is open. Yes, we did it. Very good. We can go and have lunch. It's 4 or 5 o'clock in the afternoon, but anyway. This is the intracranial, epi and lateral. Okay, we give a better look at the tip of the stent. There's something here. What is it? Sorry. What is it? We don't know. But anyway, the flow is good. So we leave it. We leave the patient and leave the stent as it is. The day after, the patient is slightly worse, aphasic, 7th cranial nerve pulse, it is arteric, mild hemiparesis, NIH is 8. We go for a new CT. This, maybe it was already there, but less evident. Now it's much clearer. Day 3, NIH is slightly better. The patient starts rehab in the ward, high blood pressure, start therapy for the blood pressure. We do an MR. There are some spots, but more or less it's similar to what we saw in the CT. Day 9, the patient is stable. Stable meaning keeping the deficits that I showed you. Day 15, while walking, she feels bad, unresponsive, confused. Laid in bed, she gets better. The US shows a very high flow inside the stent. So we go for a new CT and CTA. And here is definitely worse, definitely worse. So we decide to go back in the, this is the CTA, go back in the angio suite, and this is the what we see, distal to the distal portion of the wall stent. Collaterals are pretty nice as before, so what should we do? We decide to go for stenting, and the reason is we don't want to be too aggressive, just reopen better that we can do there. So we place a stent, not really perfect, it's a self-expandable stent from here to here. We did not a telescopic superimposition, or so we would have liked to be a little bit more proximal with the distal stent. But anyway, that was considered not bad. The flow is definitely better, so it's okay.
Sorry, Luca, this is Enterprise?
No, this is the Credo, I think.
So laser cut.
Laser cut, self-expandable laser cut, yeah. Very easy, let's say, quite easy to deploy.
Do you think that you went, when you did enter the occlusion, that you went subintimal and that the subintimal, it was open with the stent, but that part was also subintimal where you did not cover the entrance into intra?
Yeah, no, I don't think subintimal. I think it's not properly open because it didn't have the strength to open. But we were hoping it would work over time. So in the following hours, so we left the stent as you see it. Little bit.
No, but sorry.
Yeah.
The question was if the wall stent is subintimal, right?
What?
The question is if the wall stent is subintimal.
So-
Yes, I believe they
Yeah.
created a channel through the subintimal part when you, and then you connected with you went, but
Yeah,
you did not connect the intimal part or
Yeah.
intraluminal with the subintimal in the true
Yeah.
length.
I can't know. I don't have any evidence of that. The only thing is that if you go subintimal for so many centimeters, probably would occlude immediately or in the short time, and it didn't. And the other thing is that we pass quite easily, but I know it means very little. So yes, because of that, we did a balloon dilatation before leaving it, and this is the final result. It stays quite similar, but the flow is not that bad. So okay, and also the intracranial is not bad at all. So we were hoping it would work over the next hours. There's some contrastagnation, exactly as we expect. So 2 weeks after, the patient is much better, mild aphasia, no cranial nerves, no motor deficit. So she's been doing rehab in the ward, so it's okay. 3 weeks, ready to go in another hospital for completing the rehabilitation program, and we do a diagnostic angio before discharge. And this is it. Not really fantastic. But no symptoms, no additional symptoms. But I mean, it's ugly. So we didn't feel like leaving the stent in this horrible shape. So we go back in for the third time. We do the catheterization. We deploy a stent here, which is a coronary stent now. Not really easy, as you can see. We had to push a lot. Because of who knows. Yeah, the previous stent, the curve, and also that there's...
Sorry, what wire do you use here in this?
Let's say Synchro 14, maybe the Synchro 14 extra support, something like that.
For the guiding?
For
Guiding catheter.
guiding is a Neuromax, I think, again. So eventually we go up, deploy the first one, and then a second one here. So it looks good now. Intracranial is fine. It's done. No additional disasters. Stable, mild aphasia, no deficit, okay. So one question is, what was that? What did we cross? I mean, there was a occlusion of the internal carotid due to plaque at the origin of the ICA, but the interesting thing is the distal one. We might have dissected when we dilated after placing the first wall stent, because otherwise it's quite unusual to have. Or we dissected from the feet to the head. So we didn't understand. So we honestly recanalized and stented without really knowing what we were doing, which often happens. So and that's it, not finished. 6 months later, she comes back and she has a stenosis, probably of the plaque. So we went for another angio and for a PTA again. And that's the end of the story.
So Luca,
Yeah.
you've been passing through the stent or through the struts of the credo, and was it difficult to crush it?
No, I think we went through the credo in what we thought was the true lumen. Obviously, you never know it. So the only thing you can see is that you pass quite smoothly. You don't hook the struts. The markers are not moving that much. And that's the only visual confirm that you may have. There is no other way. The other thing is that by the time we went up with the coronary, it was already 3 weeks past from the deployment. So it was more stable than the
And
fresh.
just to ask you, the diameter of these coronary stents was larger, do you remember? Than a
Was
credo?
the correct one.
Was the correct one, okay. Just like the answer.
I don't know. 4.5, something like that.
I have two questions. Maybe I'm a little bit lost here. How many hours after the initiation, last seen, your first stenting happened?
At least 12 hours.
Yeah.
But probably more.
Even
Probably more. It was in the morning. Starting in the morning, she was transferred. It was probably a day, 24 hours.
And which medical treatment did she receive all the way along after the stenting?
Double from the time we deployed the first stent. It was always in double antiplatelets.
It
We
was-
started there.
Aspirin plus clopidogrel in
Exactly.
like in regular amount.
No, we did agrostat. I mean, an anti-2B3A.
For how
And
long?
From the first stent.
For how many hours? In just
It
intra-procedural?
changes by the weight of the patient, so
Yeah.
it
But for
probably
how long?
12
for
hours.
how many hours? 12
Yeah,
hours.
12
And
hours.
after that, you
You switch to
continued
the
with
double. Yeah.
that. And
We s-
and the statins also, I guess. Because
I don't know what statin means.
statins,
Yes.
statins, yeah.
We don't manage that. So
also, but
we don't use it. I mean,
Yeah.
we do not prescribe it.
Okay.
Maybe the neurologist did it.
Okay.
what we have been using more and more, and we still use, is Cangrelor in this situation. Whenever we place a stent or a flow divert or whatever, in the acute phase in emergency, we use Cangrelor, and then we interconnect with Ticagrelor, which it seems to work very well. It's easy, it's fast, it's immediately working, and as soon as you don't want it, you stop, and then 2 minutes later you have no more effect. So whenever you have to plan probably a surgery or whatever, you can stop it.
Yeah, we too.
And it's very expensive.
Switch. You need to start with Plavix before discontinuing the Agrest. Yeah.
Yes.
You
We
need
do
bridging,
a loading dose 4 to 5 hours before the end of the infusion.
But it's for every, when you switch, you need to have a bridging period with another drug.
But it's different period for.
Yeah,
different
yeah.
drugs. Thank you. Thank you.